بسم الله الرحمن الرحيم. الحمد لله وحده والصلاة والسلام على من لا نبي بعده. أما بعد, Assalamu alaikum wa rahmatullahi wa barakatuh. I am Dr. Zakaria Guennoun, consultant in diagnostic radiology, currently practicing in Saudi Arabia. And appendicitis. How many hours have I searched for you? How many times have I lost you? How many cases have I doubted in you? And how many occasions have I given up on finding you? Appendicitis is one of the most common causes of abdominal pain that needs to be diagnosed promptly so that it can be treated appropriately. And it is also the most common condition associated with lawsuits against emergency physicians. Its diagnosis is in most times straightforward, either with ultrasound or better with CT. A peristaltic, non-compressible, fluid-filled, blind ending tube more than 6 millimeters. It can contain an appendicolith and it is associated with surrounding inflammatory changes. You know the drill. Pretty simple, right? However, some cases of CT exams performed for suspected appendicitis end up being challenging to interpret. This quick talk has the objective to review some of the uncommon and atypical presentations of appendicitis and potential pitfalls. First of all, appendicitis is not always typical and obvious. It can be subtle, especially in the early phase, with just an appendiceal diameter more than 6 millimeters and no other finding. The differential in this case could be either early phase of appendicitis, for which a follow-up is required, or an other entity called appendiceal lymphoid hyperplasia, which in its core is considered as an intermittent viral appendicitis. And because viral infections are known to affect the lymphoid tissue of the abdominal mesentery, similarly, lymphoid tissue within the appendiceal wall can become inflamed and hypertrophied, causing a viral-induced appendicitis with its most typical finding, which is thickening of the lamina propria layer without lumen obstruction. You will have to rely on other findings of appendicitis to distinguish between the two, especially on ultrasound, notably the increased echogenicity of periappendiceal fat, mural hyperemia, reactive lymph node, and the most sensitive one of them, the presence of local fluid collection, which favors, contrary to one would expect, the diagnosis of lymphoid hyperplasia instead of appendicitis if present. Go figure why. Also, a quite common complication of appendicitis in adults is perforation. It tends to occur more frequently in older patients. There are no really pathognomonic signs to confirm perforation. The appendix will be a little larger, with abscess formation along its course or only at its tip. Also, there are some things that are usually found inside the lumen, which will be found now outside of the lumen because of the perforation, such as extraluminal appendicoliths, extraluminal gas, or even extraluminal contrast if you are brave enough to also give iodinated contrasts orally. And if you're lucky, you'll be able to see wall enhancement defect. Another difficult scenario that can be encountered in case of appendicitis is the phlegmon. In French, it's called plastron. It has a general definition and a specific definition for the case of appendicitis. The general definition is that of soft connective tissue inflammation of infectious nature, which is different from abscess, which is a collection of pus. And the specific definition for appendicitis is an inflammatory process, including, of course, the appendix centrally and peripherally the adjacent viscera and great omentum, which will limit the extension of the infectious process by adhering to the appendix. The findings for appendiceal phlegmon are completely non-specific. We'll see signs of focal peritonitis, sometimes associated with bowel distension because of the ileus. Look for any underlying appendicolith, which will add substantial specificity to the diagnosis. The appendicitis can also be secondary to an inflammatory process. The differential includes Crohn's disease, colitis, and the management, of course, will be different from primary appendicitis and is usually, at least initially, managed non-surgically. Sometimes the appendicitis involved only the tip, and it can complicate, same as an appendicitis involving the entirety of its length. I mean, tip appendicitis can perforate, hence it's important to follow the appendix to its tip either on ultrasound or CT. Sometimes you just cannot visualize the appendix on CT. No matter the reconstructions that you carefully review, the appendix is simply not identified on CT. Supposing that you made sure that you took your coffee that morning and that there are no technical limitations like not enough contrast injected, for example, the odds that appendicitis is present and is being missed on CT is very small, and it's not just my opinion. Several publications put the same results. On occasion, the appendicitis can be chronic, relapsing, and also resolving. It can occur when non-surgical management is attempted for whatever reason, and the CT is not distinguishable from early acute appendicitis. Also, appendicitis can be associated with rotation anomalies like intestinal malrotation and situs inversus appendix in such a way that the appendix will be visualized on the left side and not the usual right side of the abdomen, but with the same CT findings. Also, you have to bear in mind that you can have rarely appendicitis even after appendiceal surgery. In this case, the appendicitis will involve the stump, which means the residual appendix following appendectomy. Relatively few CT cases have been reported about stump appendicitis, although they are increasing in number recently. You will see an inflamed stump adjacent to the cecum and associated findings of cecal thickening, fluid, and abscess formation. Appendicitis can also be found within hernias, be it inguinal, femoral, umbilical, incisional, obturator, or spigelian. The problem is that even if the diagnosis can be easy if the appendix is just incarcerated within the hernia, it can be quite confusing if the herniated appendicitis has perforated. And of course, no lecture of appendicitis would be complete if we don't talk about possible underlying neoplasm. Because yes, underlying neoplasm in appendicitis can be found in 0.5 to 1% of appendectomy specimens. And we can understand why 30 to 50% of appendiceal neoplasms present with signs and symptoms consistent with appendicitis, because it's the result of luminal obstruction, be it from secondary infection or invasive tissue proliferation. You'll have to suspect it. If appendiceal diameter on CT is more than 15 millimeters, there are irregular nodular wall enhancements, and it will eventually lead to a distension of the appendix, filling it with mucus, leading to mucocele, which is in fact not related to a specific type of neoplasm, as up to a third are related to cystoadenocarcinoma, and its rupture will lead to peritoneal spread and pseudomyxoma.